Hi everyone, my name is Mackenzie. This is Ashley. We're part of the ABB Cardiology Fellowship this year, and we're giving a presentation on cardiac infiltrative diseases.
All right. We'll be discussing today amyloidosis, and sarcoidosis. I do that first. Take it away.
So these are our objectives, and first we'll be starting with cardiac sarcoidosis. Go on to the next. So, what is cardiac sarcoidosis? It's a multi-system granulomatous disorder with an unknown etiology. So basically, it's an accumulation of non-necrotizing granulomas that can be found within various different organs throughout the body. Specifically, cardiac occurs in about 5% of the patients with pulmonary and or systemic sarcoid. There's 13 to 25% of deaths are from sarcoid attributed to cardiac, and the average age of onset is about 50 years old. And it may involve any part of the heart, but the ventricular myocardium is the most commonly affected. So the manifestations and symptoms will either be an incidental finding or present with arrhythmias, heart failure, or sudden cardiac death. And the typical symptoms are palpitations, pre-syncope, syncope, fatigue, dyspnea, orthopnea, sudden cardiac death. And less frequently causes angina, but it's useful to distinguish between the two. So to go deeper into the symptoms, arrhythmias for conduction system disease, it typically occurs at a younger age, and an AV block is most common. First degree AV block is due to the disease being near the AV node or the bundle of His, and typically progresses to a complete block, and it may cause syncope or sudden death. Tachyarrhythmias may also occur, so ventricular arrhythmias are the second most common clinical presentation, and then supraventricular arrhythmias are a rare presenting feature, and it commonly manifests as paroxysmal atrial tachycardia, aflutter, AFib, or sinus arrest. There's a study of 110 patients that was histologically confirmed cardiac sarcoidosis, having symptomatic heart block, which was present in about 44% of those patients. Sudden cardiac death, 25 to 65% of the deaths of cardiac sarcoid come from the arrhythmias, and it may occur in the absence of any other symptoms. So you would figure out that they had sarcoid by doing an autopsy, essentially. Then cardiomyopathy and heart failure may be a presenting symptom. So if you find someone with new onset heart failure or cardiomyopathy, that would prompt an evaluation for sarcoid. It's not a common initial presentation, but most patients will present predominantly with right-sided heart failure if it is their presenting symptom. And then coronary artery disease may be associated with vasculitis. It'll often coexist, but again, it's important to distinguish between ACS versus sarcoid. So when to consider a workup for someone, patients with extracardiac sarcoidosis, adults that are under 60 with an unexplained syncope or new onset of cardiac arrhythmias, patients with aborted sudden cardiac death or sustained VT or unexplained cardiomyopathy. The preliminary test would be EKG changes, which is a low sensitivity, but you would likely see any PR interval prolongation, any blocks, QRS prolongation, atrial arrhythmias, pathological Q waves, and non-specific ST changes. And then a chest X-ray is not required, but it's usually a component to diagnose pulmonary sarcoid. And if you have any pulmonary sarcoid, you'd want to look into cardiac as well. And then lab work you typically look for would be troponins, serum angiotensin converting enzyme, serum lysozyme, and a urinary calcium. Other things to order would be Holter monitors, an echo, cardiac MRI with gadolinium with contrast. This would be the main method for detecting cardiac sarcoid to find regions of gadolinium uptake, which is most commonly multifocal and involve the midventricular wall or the subepicardium. There's no specific pattern of the uptake that's pathognomonic for cardiac sarcoid. but the main strength is the high negative predictive value. You can also get an FDG PET scan if the cardiac MRI cannot be performed, or if it's negative and there's still high clinical suspicion, but a biopsy would be gold standard. In the biopsy, you would find non-caseating granulomas on histologic examination and myocardial tissue with no alternative causes. The treatment, the main goals would be preventing the progression, avoid worsening dysfunction of the heart, managing their blocks, and any other arrhythmias associated with sudden cardiac death. You would also want to put a permanent pacemaker into this patient. You may start them on antiarrhythmic drugs if they have these arrhythmias. And then another treatment would be immunosuppressive therapies. The goal with these is to treat the inflammation and prevent fibrosis or any deterioration of the cardiac structure and function. It's not well-established regimens of the treatment. Glucocorticoids are seen to be most commonly used, and the second line would be methotrexate.
All right, so now we're going to talk about amyloidosis. I'll be presenting this part of the presentation. So what is amyloidosis? So amyloidosis generally, it's the deposition of highly ordered fibrils composed of low molecular weight subunits of proteins, most of which are normally found in plasma. Amyloid can occur anywhere in the body, but specifically we're going to be talking about cardiac amyloidosis. As I have above, it can occur, like I said, anywhere in the body, and there's over 42 different types of protein that can be associated with amyloid. There are two main subcategories of cardiac amyloidosis. So we have transthyretin amyloidosis and also light chain amyloidosis. Light chain, which is also known as AL amyloidosis, is a multisystemic disease, but cardiac amyloidosis is present in 50 to 70% of those patients who have light chain. And ATTR, also known as transthyretin, which you also may see designated as wild type amyloidosis, but people aren't really using that term as much anymore, or hereditary. It's more common in older white males, and familial is more common in young Black males. So transthyretin ATTR amyloidosis, this is the deposition of albumin, prealbumin. This is normally made by the liver, and it functions to transport thyroid hormone and retinol, which is also known as vitamin A. There are two different subtypes of the transthyretin, which are wild type and hereditary. Wild type is unknown for the mechanism of the protein deposits, but hereditary is normally caused by gene mutations in transthyretin. And there's over 120 known mutations that can cause this. So that kind of makes sense if it's found in younger people, younger Black males, like I previously said, that it would show up earlier for them. It's a gene mutation. Light chain amyloidosis, also known as AL amyloidosis, like I previously mentioned. This is more associated with a plasma cell dyscrasia. So this is more of a hematologic oncologic diagnosis. So this is treated very differently than ATTR, and we'll go and talk about that later in the presentation. If you guys need me to slow down too, let me know. I talk really fast. So clinical manifestations and symptoms you may see with either type of amyloidosis. So signs and symptoms of heart failure, especially if the patient doesn't have a previous diagnosis of heart failure. So syncope, pre-syncope, and then normal stuff, lower extremity edema, elevated JVP, which is when you see the elevated neck vein on someone's neck and they're laying at 30 degrees, ascites, so abdominal edema, and symptoms of low cardiac output. If you're, examining your patient feels cold, they have diminished pulses, they're starting to have some changes in their mental status, can all be symptoms of low cardiac output among other symptoms. So you want to keep out for that, and anginal symptoms. So a lot of things that can be in our differential, but we don't want to forget about this. These are some of the symptoms of both light chain and the transthyretin or ATTR amyloidosis. So there are symptoms of like fatigue, especially for AL, which is more of, like I said, the oncologic diagnosis. So fatigue, poor appetite, weight loss, which we would see in any cancer patient. But what I find interesting about both of these is that they all have symptoms of peripheral neuropathy. So that carpal tunnel syndrome, lumbar spinal stenosis, and autonomic dysfunction. ATTR also shows the spinal stenosis and the bicep, and also weirdly biceps tendon rupture, which I thought was interesting, but also that peripheral nerve disease. AL, you can also see hepatomegaly, GI bleed, and kidney disease, which one of the tests that we do for AL is urine test, a test for protein in the urine that can give us a clue to, should we look further into this, the test for amyloid. Okay, so these are the diagnostic and imaging findings we normally look at. So EKG can be low voltage, or it could also show that there's signs of LVH. How we further look at that is through an echocardiogram. So we would be able to use the echo to see if there's any thickening of the left ventricle. So if it's amyloid, so signs of amyloid for the AL is symmetrical LV thickening, but the wild type, you more so see it in the septum of the heart. Also non-dilator or small ventricles. And a lot of times these patients will have a preserved EF. And then if you see any of these symptoms, then we recommend doing a cardiac MRI, especially if these patients have signs of aortic stenosis, which is a whole other lecture in and of itself. But this can help detect early amyloid before LVH develops. And if this is positive, you don't need a biopsy. But if the findings on this are negative, then you would further test for serum proteins. But a diagnosis at this point can be unlikely. So like I just previously said, so proteinuria is something that we normally test for. Also increase in serum creatinine and BUN and increased LFTs. We look at these to look at congestion. So if the patient is like decompensating, like heart failure, and like that's backing up to the liver and to the kidneys, you can look at that by trending these lab tests. And also an increased BNP and troponin. So some of the tests that we look at as well are the serum electroproteins and urine protein electro at the SPEP and UPEP. I might be getting those abbreviations wrong, but basically we look at that to clue us in if this might be amyloid, as well as the kappa and lambda ratio. Kappa and lambda ratio helps us rule in the light chain amyloidosis. If any of these are positive, we obtain a biopsy, and if it's negative, we can further look at a PYP scan, which kind of similar to sarcoid looks at uptake of contrast to look at the brightness of heart to bone, which can clue us in if amyloid is like starting to develop or has developed. And we can also use bone tracer scintigraphy to look at the amount of cardiac uptake as well. All right, so treatment, like I said, for amyloid, for the AL and for the ATTR, they are very different. So if a patient has AL amyloidosis, the treatment is going to be oncologic. So you're going to have to, talk to people over on oncology to get this patient in for treatment. You have to be very careful with GDMT for these patients because the medications bind to the proteins that's causing the amyloid. So patients are at a very high risk of bradycardia and heart block, especially with like beta blockers and things like that because of these proteins. So they have a low tolerance to GDMT, which is what we use for our heart failure patients. You want to focus on diuretic therapy for these patients. A lot of times they will have preserved EF. That's a little different as far as therapy for that versus reduced ejection fraction. And then also we do this for a lot of our patients with palliative care, considering them for transplant, mechanical circulatory support. So that's our Impellas and VADs, and then inotropic therapy if they should need it. And then a secondary prevention ICD, especially if they've been having like syncope and things like that. For the ATTR amyloidosis, there's only one medication that's FDA approved for the treatment, and that's tafamidis. This only slows the progression of disease. It does not stop it, but it's pretty well tolerated. It doesn't have that many side effects. I listed a couple of other medications as well that can also be used. And then also for heart failure, you want to continue like GDMT for these patients, monitor for hypotension and intolerance to GDMT as well. And then also like the previous slide, palliative care, transplant, mechanical circulatory support, and inotropes if needed. Any questions?
Yeah, I have one.
Okay.
You said one of the treatments is transplant considerations for AL.
Mm-hmm.
But it's considered a cancer, right? And we don't transplant people generally that have cancer. Is it because it's just specific to the heart so we can transplant them?
I haven't had too much experience in patients who need transplant. I'm not sure if it would be different as far as like if it's only like cardiac amyloid, if maybe you would consider or like the progression of the disease. That's a very good question, unfortunately.
Thank you,
But
appreciate it.
that's good.
What's like the prognosis for these patients, like once they're diagnosed for like sarcoid versus amyloid?
For sarcoid, it kind of depends on if there's extra cardiac findings or if it's just cardiac specific. In what I've found, it didn't really give me a lot of like prognosis. It also depends on if you can get them to transplant or like valves and things like that as well. Everyone progresses at a different rate too.
I would say, yeah, I don't have exact numbers, but I would say pretty similar, it really depends on if these patients are tolerating medications well, and if, you need to have advanced therapies and to that.
A lot of the treatments, it doesn't solve the issue. It just, your main focus is really just slowing down the progression.
Yeah.
Is there any genetic component to sarcoid?
I didn't find anything sarcoid. I think there might be there is on amyloid.
Yeah, there is. So the wild type, the hereditary, like I said, I think there's like 120 like mutations, that's associated with it's the ATTR hereditary amyloidosis, but, the light chain, even though it's oncologic, I know there can be like, hereditary components to a lot of oncology disorders, but I didn't find anything when searching. But that's, but I would assume probably.
Good presentation.
Thank you.
Any questions from anyone online?
Ryan, just wanted to, I know you had a question to Ashley about the heart transplant with the AL amyloid, cardiac amyloid. So it's cardiac amyloid is one of the most common infiltrative cardiomyopathies and is associated with very poor prognosis. So the extent of cardiac involvement with amyloid deposition is an important determinant of what treatment options would be for the patient, and is also the major determinant outcome for patients with amyloid. So sometimes if it's only the heart that is involved, then heart transplant may be an option, because there are treatment that oncology can offer, including sometimes doing an autologous stem cell transplant. So it depends really on the clinical situation and how involved or systemic their amyloid is.
Selenia.
And Elenia, are these patients candidates for durable LVADs? Because just thinking like just putting an LVAD in obviously doesn't fix.
Probably. Now you know what, not necessarily, because most of the time these patients are they're not necessarily sometimes they don't have how to say it, they don't have heart failure reduced EF and their LV is not dilated or anything like that, because it's more of like a deposition of protein, so it's more of the stiffening of the heart. So I actually have not really seen very many patients who needed an LVAD with amyloid, with sarcoidosis and stuff.
We put one in today.
In
In a sarcoid patient
Oh, really?
today. Yeah, we did. We
Yeah,
sent some,
sarcoid.
yeah, we sent 816 for a VAD today.
Yeah.
And
Yeah. Sometimes they would need it, sometimes they don't, but it's not very common, I should say, that they would need this. Because they don't typically they don't typically have that dilated cardiomyopathy type stuff, they're not like the typical HFrEF dilated patients. Yeah. But it is the infiltrative cardiomyopathies they're great masqueraders. They could be like as you see, Ashley and Mackenzie have said that the manifestations can be a variety of things.
thank you guys so much.
Thank you guys so much. Thank you. All good questions.